presenters who will be presenting in this clinic. The last clinic, Dr. Nilima had presented the. So this is certificate of appreciation issued by the Central TB Division, NITRD, and the National Task Force, which will be given to all the presenters. So congratulations, yes, sir. Dr. Nilima, uh, for presenting the case and getting this certificate. There's next certificate for Dr. Sharabani, who presented the second case. So congratulations, Dr. Sharabani, for your presentation and for this certificate. These certificates have been dispatched to you and will reach you shortly. Thank you. And we will just start our clinic in a minute or two. Afternoon. A very warm welcome to today's difficult to treat TB clinic. I am Dr. Neeta Singla and I'll be your moderator for the day to run this clinic. And I have with me Dr. Amitesh, who is a chest physician in our institute. And we have team from Echo India who's helping us in running this clinic. We have Mr. Prateek and Mr. Manjeet who will be helping me in IT support and running this clinic. As you know, this clinic is in collaboration with Central TB Division, National Task Force, and NITRD. We have Dr. Diwan, our director, who has joined the clinic and who is supporting our clinics. Dr. Diwan, if you could say hello to our viewers.
Okay. Yeah. Thank you, Dr. Neeta, for this invitation to me. And I'm so happy that we are running this difficult to TB clinic on such a regular basis. And so many participants are already joining it. Welcome you all to this clinic, and I hope today's proceedings are as meaningful and as enriching as they have been in the past. Thank you, Neeta. Thanks.
Thank you, Dr. Diwan. We also have Dr. Rupak Singla, senior chest physician and head of the department from NITRD, who has joined us. A very warm welcome. I would also like to welcome Dr. Behra, Professor Dr. Behra, who is the National Task Force chairman and who is guiding light to this clinic. I will shortly invite him to introduce this clinic. We have Dr. Rajendra Prasad, who is the vice chair for the National Task Force and who is also the national expert for today's session. And I also welcome the faculty from Central TB Division, Dr. Ritu and others who have joined us in this clinic. A very warm welcome. I would also like to welcome chairs of ZTF and STF and faculty of medical colleges, faculty from National TB Institute Bangalore and NIRT Chennai, state TB officers, directors of STDC, and other esteemed colleagues, and also our presenters and experts for the day. Now I request Dr. Behra to introduce our clinic. Dr. Behra, you'll have to unmute.
Yes, thank you, Dr. Nita. A very good afternoon to all of you friends. Dr. Diwan, the director of NITRD, Dr. Rupak Singla, Nita, Professor Rajendra Prasad. I could see the the JTF chairpersons, STF chairpersons, then STO friends, DTO friends, and ladies and gentlemen. Again, welcome to this, I think, interesting endeavor. Mainly, it is driven by NITRD, and I should say the main person behind this is the Singla couple, Rupak Singla and Nita Singla. You know that both of them are couples, you know. So it is their initiative, it is their baby, and we are only trying to chip in to that. And it is a very, very welcome step. And I am thankful to Director of NITRD for allowing and helping us in this endeavor, where to help us, I should say, in understanding some of the difficult cases of drug-resistant TB management. Friends, as you know, there are so many things are occurring with so rapidly. You know, we have the change of regimen, change of, I think few days back, I had circulated to you all how the definition of MDR, XTR, not MDR, the XTR, pre-XTR also have changed. I'm sure all of you have got that. So it is such a dynamic process. The treatment regimens are changing. Of course, now we are stabilized with the fixed regimens. I am sure there will be no more any change. But anyway, without wasting much time, we'll all wait for the interesting discussion about the case presentation, the difficulties in handling these cases, and how the experts will try to handle such cases. And again, I am really thankful and grateful to the CTD and NITRD in particular, the Singlas, for this nice initiative. Of course, I will thank the co, which is providing this technical support. Without wasting much time, now I think, Nita, we should go to the business proper.
Yeah.
Thank you.
Thank you. Thank you so much for the introduction, sir. Thank you, sir, for the introduction. Before I go to the case, I would just like to say that I request all presenters and experts to keep a track of time, so that the second case also gets good time to present and discuss. So the case one is by Dr. Chetan Jain. Dr. Chetan, if could you raise your hand? Where are you? Yeah, thank you. I hope everyone can see Dr. Chetan. An expert will be Dr. Sridhar, sir. Dr. Sridhar, sir.
He's there.
Yes,
I could
sir.
see him. He's there.
Okay. Thank you, Dr. Sridhar. And Dr. Manoranjan Patnaik will be the second expert. And the national expert will be Dr. Rajendra Prasad, sir. So over to you, Dr. Chetan, for presentation.
Yes, Dr. Patnaik is also there. I could see him.
Yeah, thank you, Dr. Sridhar and Dr. Patnaik, for joining us. Dr. Chetan will be presenting the case, and I request everyone to put their questions on the chat so that we save time while we can get the questions as soon as the talk finishes. So, Dr. Chetan, please, you can start with your screen share.
Can you allow share screening to me, or you can start the PPT presentation?
Yeah. Yeah, it's done. Dr. Chetan, can you do now?
Yeah, just a second.
Yeah. Yes, we can see your presentation.
Okay, okay. Good afternoon, everyone. Good afternoon, sir and ma'am. So, I'm Dr. Chetan Kumar J. I'm a Nodal officer at DRTB, Mumbai. This case was presented to the DRTB clinic. I'm Dr. Chetan Kumar J. Nodal officer from DPS Ghat.
Kindly mute your Please mute your mic.
Will you be little louder, please, Dr. Saab?
Yes, sir. Yes, sir. Yes, sir.
Please.
Yes, sir. So I am Dr. Chetan Kumar Jain. I am the nodal officer with the Dot Plus site at Ghatkopar, Mumbai, run by Sarvodaya Hospital. Now, this case was presented to the difficult to treat TB clinic in October 2020. So, going to this case, this was a young, a 62-year-old male who was registered with us in Ghatkopar DPS in the month of May 2020. He's a consultant physician doctor. Comorbidity wise, he's a known case of myasthenia gravis. He was on treatment for prednisolone and pyridostigmine going on. Prednisolone 5 milligram daily and pyridostigmine was going on PDS. There's no past history of any pulmonary TB. Patient was complaining of cough, fever, weight loss, decreased appetite. X-ray was done, was showing right upper lobe cavity, for which we got a sputum test done, which was showing on a prior sequencing as PTB detected with HNR resistance as well as fluoroquinolone resistance. So he was primary pre-XDR TB, fluoroquinolone pre-XDR TB. As per the reports, he was started on all oral regimen since 9th of June 2020. Now, after starting the AKT, DST was received later on, which was showing resistant to high dose moxifloxacin. So, moxifloxacin was stopped. We had a discussion with the primary treating physician for myasthenia gravis, and after his consultation, we started the patient on amikacin injection from 2nd of July 2020. On amikacin, almost almost 5 weeks on treatment, he started developing severe giddiness, tinnitus. We got an audiogram done which was showing decreased hearing, sensorineural hearing loss present. He had visited one of the other chest physicians in the area and finally was changed from amikacin to PAS. PAS was added on 5th of August 2020. PAS was continued. Initially, he had no symptoms, but after 3 to 4 weeks, he started with severe GI intolerance, for which we had to admit the patient. Started him on multiple supportive treatment to control the GI symptoms, but there was no response. Particular severe diarrhea, nausea, vomiting. Hence, patient had to stop PAS in September 2020. After stopping PAS, patient was continued on other regimen. In the month of October beginning, he started having severe neuropathy, dizziness, lethargy, not able to go to work, not able to consult his clinic and everything. So we checked his hemoglobin and also we found to have severe anemia with neuropathy. Workup for anemia was done, was shown to have no iron deficiency anemia or no other cause. So it was labeled to be linezolide induced. Following which we had to reduce linezolide to 300 milligram because there was no other supportive medicine, so we didn't discontinue linezolide straight away. And with 300 milligram, his neuropathy symptoms are present, but it was well controlled. He was not having too much of discomfort with the neuropathy. Now, patient is supposed to get his bedaquiline finished in the month of November 2020. And after the bedaquiline gets stopped, at that time, the problem was that he will be left only with clofazimine, linezolid 300 milligram, and cycloserine. Okay. We got his investigations done clinical finding wise. So patients clinically had shown a good resolution of his symptoms. Initial symptoms of cough, fever and weight loss has reduced significantly. Patient has gained almost 2 kg of weight during the entire treatment. Neuropathy complaint were present, skin discoloration was present. Intermittent complaint of nausea, poor appetite was still present, but they were pretty well controlled with supportive treatment and diet modifications. He had shown a weight gain of almost 2 kgs. These were the lab parameters which showed that the hemoglobin after reducing linezolide to 300 milligram had come up to 11.9. Platelet had also on the lower side, but 1,23,000. This was all reports done in the month of October end. And sugars, creatinine, ECG, as all was normal. ENT opinion showed sensorineural hearing loss present. And ophthalmic evaluation had defective errors, no evidence of any drug toxicity. Weight in the month of October was around 65 kgs. Now, imaging wise, patient's initial X-ray showed right upper zone cavitary disease, which on 5-month follow-up was showing minimal scar present on the right upper zone. Similarly, CT scan was done, which was showing a right upper lobe cavitary disease has gone off, and now there are fibroatlectasis changes, which were seen on the CT scan. Now, DST pattern of the treatment initiation showed only sensitivity to PAS, clofazimine, linezolid, cana, caprio, and amikacin. Patient was resistant to rifampicin, isoniazid, pyrazinamide, ethambutol, ethanolamide, and fluoroquinolone. Even fluoroquinolone high dose was resistant, out of which patient already is on clofazimine, linezolid 300 milligram, and cycloserine. And PAS was given, but patient was intolerant to PAS. Now, follow-up culture, third month has no growth. For the fourth month and fifth month reports were not available by that time when we registered this patient at the TB clinic room. Now the query is, as when the patient goes into the CP phase, when bedaquiline gets discontinued, patient would left only with cycloserine, clofazimine, and linezolid, that is also 300 milligram, and still with the neuropathy complaint, which was pretty tolerable because weighing the pros and cons, we had to continue linezolid. So, so this was the consideration. Should we consider this patient for BDQ extension, or should we have some other regimen changes to, so that CP becomes strengthened a bit? Yeah.
Chetan, excellent presentation. Thank you, Dr. Chetan, an excellent presentation. There are many people who have joined after the presentation had started. So I will just tell you in brief what the case is. This is a case who was suffering from myasthenia gravis and was put on all oral BDQ containing regimen. Patient had to stop moxi high dose as he was on, he had resistance to it. And due to adverse drug reaction, amikacin and PAS also had to be stopped. And the dose of linezolid had to be reduced. So patient is currently on bedaquiline, clofazimine, cycloserine, and reduced dose of linezolid along with bedaquiline. Now patient is completing his intensive phase, and patient has to go on continuation phase where bedaquiline has to be stopped. So the query is what kind of continuation phase should be designed for this patient. Dr. Sridhar, before I invite you for your comments, there are few questions in the chat section. Kindly include those in your discussion. So over to Dr. Sridhar. Dr. Sridhar, sir.
Am I audible to you?
Yeah, yes, sir. Now you are audible, sir.
Good afternoon, everybody. Thank you for the opportunity to be with the clinic today. This is a really difficult case which we encounter normally in the program, where the patient unfortunately had various complications during treatment with the background myasthenia gravis. I would like to ask the presenter one particular question, because this patient was probably presented in October 2020 difficult to treat clinic. What was the decision that was taken at that time?
So after discussion with the national team, we had decided to give a trial of PAS again, which the patient didn't tolerate it. So finally, we had no other option but to extend BDQ for 3 months. And following a gap of 10 days, we restarted BDQ, and he is on extensive phase of BDQ right now.
Okay. What about the QTCs maintained? There are no other issues?
No, sir. QTCs and all are well maintained. Electrolyte wise, he is well maintained. No other adverse drug reaction. When we started in the month of November, December, he had no issues, sir.
Okay, fine. Basically, whenever we are thinking in terms of configuring a regimen, the recommendation by the CTD is ideally we should have 5 drugs in the IP when we have the BDQ and 4 drugs in the CP. Unfortunately, for this patient, from the beginning, we had one or other problems. Say, for example, patient developed the first choice of drugs for replacement. The patient could not tolerate. Because of that, in September, they have added PAS, which was also stopped in September because of GI intolerance. So under the circumstances, the national team has suggested that the BDQ can be prolonged. There was one question about why delaminate was not included. As per the recommendation of the national team, during continuation phase, will not be adding amikacin and delaminate unless it is warranted absolutely. That is a normal recommendation. And moreover, this patient was responding well and there was culture conversion. The first choice of replacement drug, IV amikacin, was effective but could not be used because of the ADR. So that made only the PAS is available. Fortunately, PAS was sensitive. But despite the advice given by the team to try again with the gastroprotective measures, still the patient could not tolerate PAS. So that left with no option because already we have compromised the regimen of linezolid to 300 mg OD. And we have other drugs only clofazimine and cycloserine, which are not robust. In that sense, the decision that was taken by the national team to continue BDQ beyond the extended, beyond the normal 6 months. So right now the patient is improving with the medications what he has been advised and the culture has converted. Radiologically there is improvement. So now the question is how long to continue BDQ? That is a problem right now. So already it is an all-over wrong regimen where the regimen is going to be 18 months and beyond. So here we have to take a call on how long we are continuing BDQ for this patient. Over to Dr. Rajendra Prasad, sir.
Thank you, Dr. Sridhar, for discussing, and thank you, Dr. Jain, for presenting the case. My one question to Dr. Jain, as I understood, his diagnosis initially was by the pyrosequencing. Am I right?
Yes, sir.
So, can you tell me what is the real specificity of the pyrosequencing? That was because the patient appears to be case of a primary drug resistance, because there was no. I believe he was a case of a primary drug resistance.
Primary drug resistance, but he was, sir, was undergone LPA because he was smear positive. We got the LPA first and second line as well as this done pyrosequencing. Because he is a consultant nephrologist in the area, so he went to one of the
So the diagnosis was based on LPA, and then pyrosequencing.
Yes, sir.
Okay. Otherwise, case seems to be well. What we see that sometimes the test may be very specific, but sometimes in an individual case, but here there is no chance to get that thing, since it was proven by the LPA and subsequently the sequencing. So I think he will, and how he behaved in X-rays.
So X-ray wise, he had a cavity which is resolved completely by the end of 5th month when we got it done in the October. It has just fibroatlectic scar seen. Also, it has shown a good response.
So he responded clinically, radiologically, and
microbiologically also, yes.
And what was the sputum for AFB in the beginning? Was positive?
Smear was positive. Culture was positive in the month of May 2020 sample.
Okay.
And 3-month follow-up culture was negative. Because it responded pretty well, so we wanted a CP phase to be strong enough so that we can don't lose the patient.
There was any history of exposure to the doctor by any family member or by any patient?
So he doesn't have any family members, but his patients are MDR and XDR positive. He's a consultant nephrologist, so he do get many of these patients. So definitely contact history is there as with the patient.
Okay. Thank you. Thank you very much.
Narendran from NIRT, sir. Very good morning to my teachers, Dr. Sridhar sir, Bera sir, Rupak sir, Rajendran sir, and all my the presenter. It was a wonderful presentation. Sir, just wanted to find out from you, do you have the CT pictures of the patient? Can you project the CT picture? Because, and how good is his myasthenia gravis being, does he have any of this myasthenic crisis?
Yeah, there are many extra sounds coming. Please mute your mics. Yeah, sorry, Dr. Chetan, please continue what you were saying. No, there was some speaker from NITRD. someone was speaking, please.
Dr. Narendran from NIRT, ma'am.
NIRT. Yeah, Dr. Narendran.
Yeah, I think he's muted. Sir, where are you able to?
Yeah, we can hear you, Dr. Narendran.
I was about to ask you what is the condition of his myasthenia gravis, because the reason is you have been repeatedly telling that it's a confined disease. See, as far as bedaquiline is concerned, we know pretty well that bedaquiline has got not much of a problem with your muscular system. There is no rhabdomyolysis, there is no myopathy, there is no aggravation of myasthenia gravis. So it is safe to continue bedaquiline, especially when you are planning to, when you have your ECGs within normal limits, and also you have your electrolytes within normal limits. So that gives you some leverage. But I just wanted to ask you, do you have the CT pictures of the patient, sir? Sir, you are muted. You have to unmute your mic.
Sorry, I don't have CT pictures right now, but it was just showing fibroathletic bands in the right upper lobe. Nothing major over there. No cavities. The cavity which was there has completely resolved.
Are there any lesions anywhere outside the upper lobe, or it is just confined to the upper lobe?
Confined to right upper lobe, sir.
Yeah, if the myasthenia gravis is very much controlled, because it will be a high risk case when you take it for surgery. Have you thought about contemplating on surgery, because it's a localized disease? That will give you a faster recovery and with undercover of drugs.
So we had thought of surgery, but a few of the senior physicians he attended, and they counseled him to not go ahead with surgery. So that is the reason he is not interested in doing that. But we do said him surgery is one of the options, because it was showing a localized disease, well controlled, and I didn't want it to relapse again in a CP phase where it is a dicey scenario. But because of the seniors, we are not able to go ahead with that.
See, the only problem I perceive is because of the myasthenia gravis that he's a high risk case. So he has to, but otherwise, if his myasthenia is well under control, there is no crisis happening, there is no weakness with this patient, he is on drugs and he is able to take care of it, then there is always a definite chance, especially because you are having very less drugs and you have all sorts of complications coming because of this thing, and you are left with very few options.
One more complications which we have right now in the month of December end. He developed a severe skin drug eruption. We had to stop the medications, and when we reintroduced, he had a severe drug reaction to cycloserine, and we had to stop the cycloserine and pass with few with the we have recounseled him for surgery again. We'll be talking him again for the surgery option. Myasthenia part wise, he has no episode of myasthenia crisis in last 4 to 5 years, and he's pretty well controlled from the myasthenia side, sir. Even with the amikacin injection, he didn't have any major issues at that time.
Yeah, thank you, Dr. Chetan. There are two questions which are saying that why delaminate was not considered at the onset before giving the injectable amikacin. I think it is more to do with availability. I think around August, September, when this happened, delaminate was not available, if I'm not mistaken. But if there is any other information that you can share with us on this?
The only reason was, as per the guidelines, we had limited options to access delaminate in adult patients. So that is the reason we didn't contemplate that measures. And so that is the reason. And amikacin, he was showing a good response, and his myasthenia physician was like, you can go ahead and consider that. So that is the reason we consider amikacin on a better option than using this thing, sir.
Yeah. So we had three questions which asked why delaminate was not considered. Number two was, is surgery considered? And you replied that yes, surgery is under consideration if needed. And third question is, can amikacin be given in myasthenia gravis?
So, ma'am, ideally we can't, but when we spoke to the physician, we gave him all the options. He suggested that because he is in a stable phase of myasthenia, just maintained with minimal dose of steroids and pyridostigmine, he said you can go ahead, we can keep a watch. If he develops any symptoms, we'll stop it immediately. But luckily, he didn't develop any symptoms related to the myasthenia, but he developed more of an area related to tinnitus and sensorineural hearing loss. So that is the reason we have to hold back this thing.
Yeah, thank you, Dr. Chetan. Dr. Rishi, you want to ask something?
Sir, just I want to know that since the patient is also a case of myasthenia gravis and patient is also started on linezolid. So, sir, vast nerve conduction studies were done before this.
Yes, sir. When he had the symptoms, we got a nerve conduction study done, which was showing sensory neural axonopathy, polyneuropathy. So that is the reason we had to stop linezolid to half dose.
Okay, but still we are continuing, still we are continuing 300 mg, we are continuing.
Yes, sir. We have planned to repeat it every 3 monthly as per the neuro opinion, or in case as well as when the symptoms aggravate.
Okay.
Thank you, Dr.
Which I
Chetan.
want,
Dr. Anuj Bhatnagar wants to ask something.
Well, there are two questions. There is a question and a suggestion, right? In this particular case. One thing is that Dr. Jain just told us that the patient had a severe skin reaction to cycloserine.
Yeah.
Right, number one. I want to ask about was the causality assessment definitely related to cycloserine? Number one. Number two, Dr. Jain, please, second. The second thing is you just told that you had done the nerve conduction studies.
Yes, sir.
But there is also a grading of neuropathy, right?
Yes,
so
sir.
what particular grade of neuropathy is the patient suffering from?
So grading is not done, sir. But he has a neuropathy involving the lower limbs only. We have not done the grading, sir. From the casualty assessment for the cycloserine, so when he had a severe drug reaction, we had to stop all the medications which was going on, and then we reintroduced one, and in reintroduction of cycloserine gave him a severe skin reaction. So again, increase in the skin reactions. So we had to stop cycloserine, and after discontinuation, that patient had no symptoms. We initially thought clofazimine can be a cause, but he responded pretty well to clofazimine. He's tolerating well clofazimine, sir.
Thank you, Dr. Chetan. We have
basically right now you are left with cycloserine and
no, sir. We are left with
clofazimine and
bedaquiline extension and pass with some amount of support and some GI intolerance. We are accepting it, but we are trying to convince him for surgery for that reason, sir.
The patient is a fit case for surgery actually, because this is the last resort for this particular patient, taking into mind every see for this particular patient. If you see, the complication is that the patient is in a continuation phase.
Yes.
You please grade the neuropathy. If it is more than grade 2, till grade 2, you can actually continue with the reduced doses with repeated checks. But the moment it reaches grade 3, then you will have to discontinue with this also.
Okay, sir.
You don't have drugs left. Now the question is how long to continue bedaquiline. Now you need to continue minimum 3 drugs in this patient in the continuation phase. The question is how long to continue bedaquiline.
Yes, sir.
Now in the latest, in the different studies that have been shown that it has been very well tolerated. In fact, it has been for the entire duration of treatment. In fact, up to they have actually continued for any continuation of bedaquiline beyond 203 days. I mean, the critical time is 180 days. Beyond 203 days, there is no effect much on the QTC interval. You can continue the bedaquiline. Now, can you add delamanid right now in the last 12 months? Difficult to answer, because unless you have every other option closed, that's the only reason why you will have to design a regimen with bedaquiline plus delamanid as of now. But here it is a patient who has to have a prolonged course of delamanid, preferably for the entire duration of treatment. But the first consideration right now is to motivate the patient for surgery. Thank you.
Thank you. Thank you, Dr. Anuj. Before I invite Dr. Singla for his final comments on this case, I would like to read out comments by Dr. Divan, our director, who is an eminent thoracic surgeon. And he says that this is an ideal case for surgery in addition to medical management. So do consider this case for surgery. Dr. Singla, now I invite you to give final recommendations for
Dr.
this
Neetu,
case.
Dr. Neetu, Padma here. Can I just ask something?
Yeah, Dr. Padma.
My two questions to Dr. Chetan is, point number one, how long has he received the bedaquiline? Is it 6 months or 9 months? Point number two, how long he wants to continue the bedaquiline and why? What is the rationale that they want to continue it beyond the 9 months period?
Ma'am, so he is on 8th month of 9th month has started now. He is on 9th month of bedaquiline right now. And the rationale is only because we don't have much drugs left for the CP phase. Okay, we are left with only clofazimine, linezolid half dose. Because of the neuropathy, I'll grade it and see whether we can continue it further or not. Bedaquiline on 9th month going on, and after that at least 4 drugs which is required in the CP phase that we are not able to achieve that. Cycloserine had a severe drug eruption, so we are he started on pass but not tolerating much, but with the supportive treatment we are continuing him on the pass. So we have very limited options left for us. Surgery was contemplated, we tried to convince him, but not a good response because many of the seniors told him to hold back that reason. But now I need to reconsider him for that, and we are recounseling him again for the same option. So That is the reason we need to reconsider him for an extensive period of bedaquiline.
Thank you, Dr. Chetan. And
Dr.
welcome,
Chetan?
Dr. Padma. Nice to have you here.
Dr. Chetan?
Yes, sir.
Dr. Chetan?
Yes, sir. Yes, sir. Yes, sir.
Did you have subsequent cultures also? What was the result of?
So third month was negative by the time we presented. Fourth month is also negative. After that, it's not able to give good amount of expectoration, so we are hold back. So
Right.
third and fourth we know which is negative.
But I totally agree with Dr. Diwan that since the number of drugs and he has lot of problem with the drugs and number of drugs are also less, so he is a very fit case if he agrees. Best is to remove that area and so get rid of the disease because drugs are very, I mean, they are not for him. He is facing lot of problem with most of the drugs and number of drugs is also less. So that's the ideal choice. I totally agree with Dr. Diwan. Okay.
Thanks a lot.
Dr. Chetan, I just want to caution here. BDQ is not like any other drug, like you go on continuing the drug just because we have no other options, because see, the supporting drugs that you have may not be as strong as you think they are. So let's say if he doesn't convert, if he doesn't respond till 12th month, do you want to continue it like 15th month, 18th month? Your supporting drugs are very weak. So that really has to be considered. Just continuing bedaquiline because we don't have any other drugs to offer may not be the right choice. So this is just for your consideration. I'm only worried that we are developing now resistance to BDQ, which is again increasing. So do consider your supportive drugs also. That is not being considered at all. Thank you.
Thank you, Dr. Padma. Dr. Singla, we would like to have your final recommendations for this case, and then we will close this case.
So, thank you very much, Dr. Chetan, Dr. Padma, Dr. Diwan, Dr. Indra Prasad, sir, for their very wise comments, and of course, Dr. Sridhar also. You see, this case has multiple issues. Now he has completed around 9 months of treatment. And in the follow-up phase, fortunately, he has achieved culture conversion at 3rd month and even at 4th month. And we believe, although he's not able to give sputum, that he is remaining to be converted. That is what we are believing, looking at is the description of the X-rays and CT scan. Now, the 2-3 issues which are being, one is this, you see, continuing the linezolid at 300 milligram with axonal degeneration already demonstrated. As Dr. Anuj asked, you see, in these cases, we have been using linezolid in our institute since 2005. And what we have experienced is that in case they have this kind of neuropathy, and even if we continue with low dose, sometimes it leads to irreversible damage to the nerves, and patient is left with this neuropathic symptoms the rest of the life. So gradually we realize that once patient has significant symptoms, in that case, it is ideal not to continue with the lower dosages, provided we have some other drugs to which can be supportive to the patient. So that we have to consider whether to continue with the linezolid or not to continue, because in case he's left with permanent neuropathic pains, it will not be a good scenario. Now coming to this other drugs which are left past, he already did not tolerate it, had to be stopped earlier. And now we are trying to continue with it, and we don't know how long he will be able to continue with the PAS. So even that thing we have to keep in mind. Bedaquiline extension, as Dr. Padma already warned, that it is of use only when you have good supportive drugs. So supportive drugs practically we are left with is the clofazimine. So since he has already converted, the 9 months are already over. So in this case, an early surgery, that is to reduce his bacterial load, whatever is there, will be a very good option. So we need to discuss with the patient that in your case, now the drugs which are remaining with us are very, very few. And in case we do the surgery, we remove this part of the lung, the bacterial load will be less. So that would be a good option for this patient to add surgery. Regarding why delaminate was not added earlier, you see, as per the current the guidelines which were there at that time, the first drug to be considered was pyrazinamide if sensitive, then injectables if sensitive, ethionamide if sensitive, like that. So at that time, the delaminate was not there in our national guidelines because the evidence of giving bedaquiline plus delaminate together which could increase the QTC prolongation was lacking in the country. So our National Technical Expert Group had taken a call that not to give them together as far as unless it is extremely essential. And now in the newer guidelines which are being now revised, even the WHO has shown the evidence that at least the safety, that if bedaquiline and delamanid are given together, there are studies which have shown that it could be safer option. So now in the new guidelines, just for information, the delamanid will be the first replacement drug to be considered. But let that document be out. But it's just for the knowledge of the people who are attending that now the delamanid will be there along with the bedaquiline in case the one of the drugs in the initial phase is not tolerated. We may add it. So I think excellent case, Dr. Chetan, and we have discussed so many things through this case, and we want that other Doppler sites also they take out such interesting cases through which we can discuss many cases at the national level. Thank you so much. Thank you.
Uh, Thank you, Dr. Singla. So as you,
One thing.
yes, sir.
Yeah, you see, Dr. Alpa Dalal has asked, is it possible to consider delalamide now? I don't think. What is the correct answer, Dr. Rupak?
Yes, you see, this is again a question. Normally speaking, as our guidelines, delamanid is to be given in the first 6 months. Although there is no strong contraindication for using it in the rest of the 6 months. Suppose in this case we find that we have to stop PAS, we have to stop linezolid, we are left with only 2 drugs, that is bedaquiline, which is being extended, and clofazimine. In that case, as an exceptional case, with the consent of the national level experts, we may consider giving delamanid in this case.
Thank you, Dr. Singla. So, Dr. Chetan, what have you decided for this case after going through all the comments? What would be your continuation phase for this patient?
Ma'am, if the ma'am, first option would be I'll try to convince the patient again for the surgical option. So if we get rid of the disease load, that's the first best option available. For the continuation phase, if the national guidelines, national committee allows us, then definitely considering the pros and cons, we might add a newer drug that is a delamanid. If we can continue with delamanid and a bedaquiline for a short period of time, with clofazimine and support of PAS and linezolid at the low dose, if the grading of your peripheral neuropathy is less, then I think so that would be an ideal regimen with surgery removing out the disease and continuation phase of these medications for the longer term. So that would be a good options available for us.
Thank you, Dr. Chetan. So as there is commitment of this difficult to treat TB clinic, that the experts who have done the hand-holding for this case will continue to do the hand-holding for next 2 years till the patient completes his treatment. So anytime you are stuck anywhere and you face any problem, please do contact your experts. So just for the information of people who might have joined us for the first time, how this clinic works is that whenever there's a difficult case with any nodal DRTB center, they send the case to Central TB Division. Central TB Division has identified about 20 experts who are willing to give their time and expertise for these patients. And they would provide immediate solution to the person who has sent this case. And then that is part 1. And then as a part 2, we do the capacity building of people who are in the field by presenting these cases on this forum and discussing them. So what we have done today is part 2, and part 1 has already been done by Dr. Sridhar and Dr. Alpa for this case. So thank you, Dr. Chetan, and all the experts for discussing this case and making it very interesting for us to learn. Thank you so much. And now we move over to case 2. Case 2 is by Dr. Chandrakanta, and he is from Nodal DRTB Center, Jodhpur. Over to Dr. Chandrakant for his presentation. And the expert for this case will be Dr. Alpa, and the national expert is Dr. Rajendra Prasad.
Good morning, respected teachers. I am Dr. Chandrakant, resident at Dr. SN Medical College, Jodhpur. Today I am presenting a multi-drug resistance pulmonary tuberculosis case history of a patient. stuck हुआ है. A 24-year female resident of Pali district, Rajasthan, was admitted at Cane Chest Hospital, Jodhpur. Her total duration of illness is 4.5 years. Now of cough, easy fatigability, loss of appetite and weight. There is no history of addiction. By occupation, she is doing household work. There is no history of contact with non-case of pulmonary tuberculosis in her family. Past history or treatment chronology. There is a history of hospitalization, never prolonged but for short duration, few times, and OPD consultation for similar illness on and off past 4.5 years. There is no history of diabetes, hypertension, COPD, or asthma in the past. First, in 2016, she took DOTS for 6 months from nearby her residence, a government setup. From August 2017, she started private ATT for 8 months till March 2018 from a private hospital in Palanpur. On 24th March 2018, her CVNAT report was suggestive of MTB detected and R resistance. For that, on 18th April 2018, conventional regimen containing kanamycin, levofloxacin, ethionamide, ethambutol, pyrazinamide, cycloserine was started. Initially, patient was taking medicines regularly, but later half of the course, patient was keeping medicines 5 to 10 drugs per month. Her culture reports were negative till 9 months, but 3 cultures were positive for this patient on 12, 15, and 18 months. And culture was negative at 21 months, and at 24 months, culture was not done. Patient was not in follow-up, maybe due to lockdowns. And in April 2020, outcome of this patient was declared as failure.
Hello.
On patient was having subsequent on and off complaints, so patient went to again to a government setup on August. Her sputum microscopy was done and that was positive, and subsequently CBNet was sent. CBNet was MTB detected and R resistance on 15th August. But patient took some indigenous medicine for nearly 2 months. Then patient went to RNT Medical College, Udaipur for treatment, but they referred to Nodal DRTB Center, Jodhpur. On 11th November 2020, second-line LPA report came, which was suggestive of FQ resistance, high dose, and SLID sensitive. Patient came here, but as patient was COVID positive, so patient was referred to dedicated COVID hospital. Patient came again in January 2021 with FLPA suggestive of CATG mutation 1% and INHA mutation was absent. On 12th January 21, patient was started on all oral longer regime containing bedaquiline, linazolid, cycloserine, clofazimine, and pyrazinamide and ethionamide. This is the X-ray of the patient suggestive of left upper and middle zone fibrocavitary disease. As per PMDT guideline, her treatment evaluation was done. All the blood parameters were within normal range. Weight is 40 kg. Cardio reference is QTC is normal 428. Psychiatry, they suggested tablet alprazolam 0.25 half HS for anxiety and depression, and ophthalmology, vision and fundus were normal. So, sir, latest result for this patient is sputum microscopy on 7th August 2020 was positive. CBNAT 15th August 2020 MTB detected and R resistance. In SLPA on 11th November 2020, there is in Gyri A mutation 3C was present and SLID were totally sensitive. In first line LPA, which came on 11th January 21, CATG, there is mutation 1% and INHA mutations were absent. So individual drug sensitivity pattern based on latest LPA and CBNAT pattern. Isoniazid and R resistance. Second line injectables, streptomycin, kanamycin was sensitive. Levofloxacin, moxiflox, high dose moxi resistance. Ethionamide sensitive, and DST for pyrazinamide and ethambutol is not available, sir. Details of drug taken in the past. Isoniazid and rifampicin taken for 14 months during first DOTS and second private ATT. Pyrazinamide, ethambutol were taken during first DOTS, second private ATT, and ethambutol during the conventional regime. Streptomycin was given for only 3 months during second private ATT for which she took 8 months. And kanamycin is given for 6 months during conventional regime. Levoflox, cycloserine, and ethionamide were given for approximately 23 months, which later on was irregular for around 23 months during conventional regime. So, ma'am, here is a case of multi-drug resistant pulmonary tuberculosis with R resistance, H resistance, FQ resistance, including high dose moxi, but ethionamide sensitive, SLID sensitive. Currently, we are not having delaminate, and there is no DST of pyrazinamide and ethambutol. So, what will be the ideal regimen for this patient?
Yeah, thank you, Dr. Chandrakant. You have already designed a regime and you have put patient on treatment, but your question is this the ideal regime for the patient? So over to you, Dr. Alpa, for your comments. Dr. Alpa is the expert for this case. Dr. Alpa Dalal.
Yeah.
Yeah.
Good afternoon, everyone. Dr. Singla, Neeta Singla, can you allow me to share my screen?
Sure. Yeah, it's done. Please, Dr.
Yeah, okay. So good afternoon to all my seniors and all the experts. So I had some comments and I have prepared few slides to give my opinion or just for setting up the discussion. Can you see the screen?
Can you do the slideshow, please? Yeah, full screen.
Achha.
Yeah.
Full screen now?
Yeah, it is clear.
Okay. So thank you, Jodhpur team, for a very good presentation. So what I see in this patient, that she has a prolonged history, almost 4.5 years she's been taking treatment. She's already exposed to a lot of first line and second line drugs. She's a young female, she's a housewife. Here we have FQ resistance, CATG resistance mutation is present, mutation 3C is present, and SLID is sensitive and INHA is absent. And currently she is on bedaquiline, linezolid, clofam, pyrazinamide, ethionamide, and cycloserine. So she is on 6 drugs. So out of this, bedaquiline she is never exposed to, linezolid she is never exposed to, and clofa she is never exposed to. So they are likely to be sensitive. Z she's already received for more than 6 months. Cycloserine almost she's received for 23 months. And ethionamide we are assuming to be sensitive based on the absence of INHA mutation. Now X-ray chest we are seeing here there is extensive disease, though it is unilateral, but it's extensive. Albumin is low, so she
भी थोड़ी देर में आना है
so she has
अभी हमारा
she has a poor nutritional status. Her BMI is low. She is just 40 kg and 155 centimeter of height. So here is a patient who has extensive disease, who's got pre-fluoro XTR, who has been taking treatment for 4.5 years, and she has comorbidities of malnutrition, anxiety, and depression. So what are the issues with current regimen that I see? The 3 drugs to which she is never exposed and likely to be sensitive are present in this regimen. But other drugs she has had long exposure. We are assuming that ethionamide would work in absence of INHA resistance. And when the intensive phase is over and if bedaquiline is stopped, this regimen is likely to become a weak regimen and higher chances of failure. And which are the drugs she's never exposed to? Bedaquiline, linezolid, clofa, PAS, and imipenem. So what are my suggestions? First of all, she's already been exposed to cycloserine for a prolonged period and she's already having anxiety and depression. So I do not see much point in continuing cycloserine. But of course, provided we are able to constitute a good regimen with other drugs. Addition of PAS is an option that can be considered, but we have seen ethionamide and PAS together, and especially in young females who are already malnourished, causes a lot of GI issue and further compromises the nutrition, and this fact has to be considered. Aminoglycoside, yes, but again, this lady, she's a very thin, malnourished lady, hardly any muscle mass. If we start her on aminoglycoside and if we give her IM, and she has had a lot of defaults in the past, so how wise it would be to give amic acid. If delaminate is available, and also in one of the replacement sequences mentioned that if we are not able to use moxifloxacin high dose, then we can consider addition of delaminate to this regimen, bedaquiline based regimen. So that is to be considered. And again, like Dr. Chetan Jain's case you discussed, and a lot of issues are brought out, and we do see this in real life situation, especially for a lady who is undernourished and underweight, and we see a lot of GI intolerance, and even in these patients, linezolid induced neuropathy is very common. So these patients, we have to foresee and we to consider that if she develops intolerance to linezolid or PAS, then again our regimen may become weak. So we have to consider extension of bedaquiline. Nutrition has to be paid attention to. She should receive high calorie, high protein and diet with multivitamin. Counseling is very important throughout the course because of her past history of default and depression, and follow-up monitoring. And again, in this case, I would say that surgical option should be considered once the patient is culture converted, for two reasons. One is that she's had past history of default. She has extensive disease unilateral, and she already has cavitating disease and a bad resistance pattern. So if possible, then we should consider a surgical option for her. And I'm sure screening and infection control would have been done in this case.
Thank you, Dr. Alpa. There is a comment from Dr. Divan, again, our thoracic surgeon and our director, that this patient is again ideal for surgery. So surgery should be an option for this patient. Are there any other comments or questions?
Can I add something here, Dr. Neeta?
Sure, sir. Sure, sir.
Yeah. With the size of cavity which is seen, it is whatever treatment, however long you may do, you may make her occasionally negative. She will become positive again.
Yes.
Of course, the extent will be pneumonectomy. Nothing less than pneumonectomy will be required in this case. And maybe at 40 kg of weight, she may not be immediately fit for it.
Yes.
So what we consider is admitting this case, building up the case. This may take up to 3 to 4 weeks with good nutrition under supervision in the hospital, and then taking up for surgery. And that gives her, and then continue whatever treatment you have mentioned. That gives her the best chance of survival, and that's my take on this case.
Thank you, Dr. Divan. Your presence really helps all the patients who are, because earlier we didn't have so many comments on surgery. So thank you so much for being there. SMO Gorakhpur wants to ask some question.
Madam, Dr. Narendran from NIRT.
Yes, Dr. Narendran.
Just two comments. I really agree with Divan sir that yes, this patient is with that amount of a cavity. It's really difficult for you to control the disease. But there are two words of caution having worked in the cardiothoracic department. One is that, of course, they will be doing as a preoperative procedure. We will be looking at the stump, because the extensive disease always the bronchial stump is not that good, healthy enough, so that when you put it, they go in for a bronchopleural fistula very commonly, especially with TB. Secondly, what is seen as unilateral in the chest X-ray may not be the same when you look into the CT. So obviously they will be looking at the CT.
So here the question would be that in this patient who is already defaulted in the past and she has a low muscle mass, so delaminate would be an ideal choice to replace rather than amikacin in this patient. So if delaminate is available, I think that would be an ideal choice to continue all oral regimen in this patient.
Yeah, thank you, Dr. Alpa. And I think that's why Dr. Anuj Bhatnagar has written in comments that we should wait for the guidelines to come out, the 2021 guidelines, where the delaminate is first choice of drug.
Currently, then, yes, Singla sir.
Yeah, you see, thank you very much, the team from Jodhpur, as well as Dr. Alpa and Dr. Divan. You see, in this case, as Dr. Alpa already discussed, because of the prolonged use and also having this depression, so cycloserine definitely should not be a good choice. I think same thing I'll put up for ethionamide also. Although it is saying that ethionamide, the INHA mutation is not there, it's likely to be sensitive, but patient has used this drug also for quite a long time. So even this may not be considered an effective regimen, especially with a patient having the unilateral sort of destroyed lung, wherein we are even thinking of surgery. So we have to make a very robust regimen, which should be able to make him culture negative, so that an early surgery can be considered. So among these drugs, already discussed, we have used linezolid, never used, clofazimine, never used. These three drugs are with us. Then coming to PAS, as we all know, sometimes the tolerance to PAS is not there, although we'll consider it as an effect. It's again a bacteriostatic drug only, but that will be the another drug in the regimen. The next question will be amikacin versus delamanid. Patient has already received this drug, the injectable drug for 6 months, has the poor muscle mass. So in these cases, sometimes they don't, and already defaulted also. So in these cases, sometimes they don't take it well with the injections. And in case, definitely in case available, I'll consider delamanid rather than the injection in these cases, so that we can build up an all oral regimen with a likelihood of better compliance with this. And regarding the surgery, yes, although apparently on X-ray it looks like unilateral disease only, but as already from NIRT team, they said that once you do the CT scan, only then we'll come to know the right side. And sometimes when they open up, as we have seen with our surgeon, it is even beyond what was seen in the CT scan. So that thing also has to be kept in mind. So if surgery option is there, yes, we should seriously consider the surgical option, provided his lung functions are supportive and other things are not there. And also just to share with our own experience at this institute where we have been doing the pre-operative assessment of these patients, what we have noticed is when you remove a lung, patient is not losing 50% of the lung functions. As we conventionally see in the ATS guidelines or British Society guidelines, what we observed is because we are removing a diseased lung. So here the loss of lung function, what we have demonstrated is around 3% per segment. So we expect that instead of losing 50% by removing a lung, patient may just lose around 30 to 35% of the lung function. So we also have to keep that thing in mind before we say that no, this patient is unfit for surgery. So these aspects also, because in this case, surgery definitely, as Dr. Diwan also said, is a serious consideration to be considered to help the patient. Otherwise, he's going to relapse again, as he has done earlier also. So these are my comments. Thank you.
And sir, also about as we go along with the treatment and we introduce say PAS and delaminid and linezolid, and we'll have to see how she is tolerating these drugs, and if one or two of these drugs have to be taken off because of the ADR, then we'll also at the end of 6 months we'll have to consider whether bedaquiline extension has to be considered in this case.
Yes, definitely. Although we will be reaching this part a little later, but yes, we'll have to consider that seriously. That in case is not able to tolerate, which very commonly they're not able to tolerate, the things like linezolid or PAS, we may have to consider the extension of the bedaquiline.
Dr. Rupak? Dr. Rupak?
Yes, sir.
Yes, I think case has been very well discussed. One more point I would like to, as she has been a chronic case of tuberculosis and has been a drug defaulter in the past also. That is why she has reached to this stage. So I think the adherence must be there. It's not simply that because now drugs are very few. And so that portion has to be looked up very carefully, especially for the team, that see whatever drugs you are prescribing, she must adhere to those drugs. So regular follow-up and adherence, and if possible, the dots should be done so that she completes the therapy. And I agree with Dr. Diwan, for such cases, they are likely to recur and likely to relapse. So surgery, if it could be done and she could tolerate the surgery after the preparation, then that would be the probably final choice to save this lady. Otherwise, we have seen such ladies are usually keep on defaulting even with these drugs, and ultimately they die. So that is my comment that the strict adherence policies is to be followed about the drugs.
Yeah.
Yes, sir. I think what you have said is very, very important. And sometimes we may have to admit the patient to ensure adherence, especially in the initial 1 to 3 months. And in this admission period, we can also build up this patient nutritionally. So, because in this case, we can't afford not to be adherent with a patient who has been non-adherent in the past. So, even
Yes.
consideration of admission for 1, 2, or 3 months, I think that should also be considered.
Yes, yes, totally agree. Totally agree.
Thank you, sir. There is a question that if amikacin has to be given for a long duration, can we put in a port or should we put in a port? Dr. Alpa, would you like to? There's a question, should we put in a port to give the long-term amikacin?
We nowadays, when we are giving the patient salvage regimen, we put a PICC line. So this PICC line works well in these patients. That can be considered if we are giving the patient for considering giving amikacin for 6 months, and that would be a good choice. Or otherwise, then we have to give IV cannula, and maybe every 10 days IV cannula has to be changed. But I think PICC line would be a good option because for putting in a port has its own complications, and we do get infection of the port, especially in periphery if it's not managed well. Then
no audio, please. Audio is not there.
Yeah.
Okay. Thank you, Dr. Alpa. We are now running short of time. So, Dr. Alpa, there are 3 questions on the chat. Can you go through them and give the reply on chat? And meanwhile, we are putting up a feedback, this thing for you to answer. There are last time we got very less number of feedbacks. So I request you all to please fill in the feedback form. Meanwhile, Dr. Alpa will be replying to our queries. If there are any comments, we can take 1 or 2 comments if there are any comments. So we will be sending the certificates for Dr. Chetan and Dr. Chandrakant shortly. You will be receiving your certificate of appreciation, and both the presentations were excellent. So we thank you both the presenters for making the presentations. And I would like to take this opportunity to thank Dr. Diwan, Dr. Behra, Dr. Rajendra Prasad, Dr. Padma, Dr. Rupak Singla, and all the other experts who have joined us, and also all the chairpersons of ZTF and STF, faculty of medical colleges, faculty from NTI Bangalore, NIRT Chennai, STOs, director of STDCs, and other esteemed colleagues. Thank you so much for attending our clinic and being there and for supporting us. So now we are waiting for your feedback on the poll that we have just floated. We can take some questions till the time people are filling in the feedback forms. If there are any burning questions or comments, we can take them. Yes, Dr. Rishi, you want to say something?
Madam, just as per the all experts' comments, we have said that surgery, urine letter surgery is option here. But just I want to ask at this stage, can we do DST for parazinamide? Because at present, Jodhpur, they have not done as per your history says. So from the BAL or can we do DST for that? Because at least we can know that previously he might have been taken, she might have been taken all ATTs, but we don't know the exact status of parazinamide.
You see, Dr. Rishi, the patient is a case of category 4 failure, conventional regimen. And here also they receive PZA. Definitely, the culture must be available. We should do the PZA sensitivity so that we have another drug in the armamentarium. But patient has taken PZA for a sufficient long time. So we may not be able to rely much on this. In a patient who has received the category 1 earlier than category 4 and has failed to treatment. But yes, it should be considered in case we are cornered, we will have one drug with us in hand, wherein we can consider it. So that point is very well taken.
Very good comments from Dr. Ira Shah also. I request everyone to go through chat. She has given some good comments. There is a question from Dr. Homa. It says a pyrazinamide phenotypic test is not reliable now. WHO has recommended genotypic testing as reference for pyrazinamide. So that was a comment.
But the issue is it is not available in our country as of now under the government setup. So that is an issue. So still we are going with the phenotypic PZA. But yes, once we have it available, and it's faster also.
Thank you, Dr. Singla. So we encourage all the nodal DRTB center to refer their difficult to treat TB patients to Central TB Division on the email dt3c@gmail.com, so that we can help you with solution to your cases. So keep sending your this thing, and you have our email ID also, through which you have received the invitation. So in case you are not able to reach the CTD, or if you have any issue with the email, you can send the mail to us and we can redirect your mail to them. And if you want us to contact you on WhatsApp, so on the chat section, you can write your name, your designation and phone numbers. We will add you to a WhatsApp group where you will get the information on these clinics, or you can send any queries also. So if you want to be added to that group, please send your phone numbers on the chat section. Yeah, so we are now sharing the certificates of Dr. Chetan and Dr. Chandrakant. These certificates will shortly be sent to you physically also. Please share the certificates. Yeah, Dr. Chandrakant, that's your certificate of appreciation from this clinic. And Dr. Chetan, that's your certificate. Thank you for the excellent presentation, Dr. Chetan, as well as Dr. Chandrakant. So thank you, everybody. And we are now closing the session. Thanks a lot.
Thank you, Neeta. Thank you all.
Thank you,
Thank
sir.
you, Alpa.
Thank you, sir. Thank you.
Thank you.
Yeah, thank you all the experts who give so much time to these patients and preparing these cases. You are a big support to us.
Thanks, Dr. Working so hard, madam. And
no.
This is expected.
Thank you, ma'am. Thank you very much.
Thank you, ma'am.
Bye, NITRD.